I need to tell you something that might shock you. Not every medical test your doctor recommends after age 65 is actually helping you. In fact, some of them could be doing more harm than good, and the medical establishment doesn't want to talk about this because it challenges everything we've been told about preventive care. I'm Dr. Nova Mind, and I've spent 15 years in geriatric medicine. I've reviewed thousands of patient cases, examined the latest research, and consulted with leading experts in evidence-based medicine for older adults. What I've discovered has completely changed how I advise my patients over 65 about medical testing. There are 5 specific medical checkups that I would personally decline if I were over 65, and I'm going to explain exactly why, backed by peer-reviewed research and clinical guidelines that most doctors never mention. The last one on this list is particularly dangerous. It's a test that millions of seniors get every single year, thinking they're being responsible about their health. But the research shows it can trigger a cascade of unnecessary procedures, treatments, and complications that significantly reduce quality of life and can even shorten lifespan. Before we dive in, let me be absolutely clear about something. I am not telling you to avoid all medical care. I am not anti-medicine or anti-testing. I am pro-evidence-based medicine that actually benefits older adults. The tests I'm going to discuss today have been evaluated by major medical organizations, and the consensus is clear. After a certain age, for most people, the risks outweigh the benefits. A landmark study published in JAMA Internal Medicine found that overscreening and overtesting in adults over 65 leads to what researchers call the cascade effect. One unnecessary test leads to another. A false positive leads to invasive procedures. Side effects from those procedures lead to hospitalizations. And suddenly, a healthy 78-year-old ends up in a nursing home because of complications from testing for a disease they never had. The American Geriatrics Society publishes specific guidelines about which tests should be avoided in older adults. But many primary care doctors, who aren't specialists in geriatrics, continue ordering these tests out of habit, fear of liability, or simply because that's what we've always done. Today, I'm going to give you the information. You need to have an informed conversation with your doctor. Information about which tests make sense after 65 and which ones you should seriously question. If you're over 65, or if you have a parent or loved one who is, this video could literally save their life or protect their independence. Hit that like button right now if you want honest, evidence-based medical information, and subscribe to this channel if you want weekly videos on navigating healthcare wisely as you age. Let's get into it. The first medical checkup I would decline after 65 is routine colonoscopy for colorectal cancer screening. Now, before you close this video thinking I'm crazy, hear me out. Colonoscopy is an excellent screening tool for colorectal cancer. It saves lives. But the key word is screening. Screening means looking for disease in people who have no symptoms, and screening only makes sense when the benefits outweigh the risks. Here's what most people don't understand about cancer screening. It takes years, sometimes decades, for screening to provide a survival benefit. When you screen for colorectal cancer, you're looking for polyps, small growths that might turn into cancer in 10 to 15 years. You remove those polyps today to prevent cancer 10 years from now. But what if you're 78 years old? The U.S. Preventive Services Task Force, which is the gold standard for evidence-based screening recommendations, explicitly states that for adults aged 76 to 85, the decision to screen for colorectal cancer should be individualized. And for adults over 85, they recommend against screening entirely. Why? First, the time-to-benefit problem. A comprehensive analysis published in Annals of Internal Medicine found that it takes approximately 10 years from the time of colonoscopy to see a mortality benefit from screening. If you're 78 and your life expectancy is 8–10 years, you will not live long enough to benefit from finding and removing a polyp that might have become cancer in 15 years. Second, the risks are real. Colonoscopy isn't just uncomfortable. It carries genuine risks that increase with age: perforation of the colon, a tear in the intestinal wall requiring emergency surgery, significant bleeding, especially if you're on blood thinners, cardiovascular events during the procedure, or bowel prep, dehydration and electrolyte imbalances from the bowel prep, complications from sedation. A study in JAMA found that adults over 65 have a significantly higher rate of serious complications from colonoscopy compared to younger adults. The complication rate can be 3–4 times higher. Third, the bowel prep itself is dangerous for older adults. The preparation for colonoscopy requires you to completely empty your bowels using powerful laxatives. For an older adult, especially one with kidney problems, heart conditions, or who takes certain medications, this can cause severe dehydration, dangerous drops in blood pressure, electrolyte imbalances that can trigger heart arrhythmias. Falls from rushing to the bathroom repeatedly. I've personally seen patients hospitalized because of complications from colonoscopy prep, not even from the procedure itself. Fourth, false positives and overdiagnosis. Not every polyp found will turn into cancer. Not every tiny cancer found will grow fast enough to cause problems in your remaining lifetime. But once something is found, the medical system pushes you toward treatment, removal, surgery, chemotherapy. For a 45-year-old, aggressive treatment of early cancer makes sense. For an 82-year-old with heart disease and diabetes, aggressive cancer treatment might cause more suffering than the cancer itself ever would have. What the guidelines actually say: the American College of Physicians recommends against screening colonoscopy in adults over 65 who have had previous negative screenings. The American Geriatrics Society includes colonoscopy in adults over 85 on their choosing wisely list of tests that should be avoided. When might colonoscopy still make sense after 65? If you have symptoms, if you're having rectal bleeding, unexplained weight loss, change in bowel habits, or anemia, that's not screening anymore. That's diagnostic testing, and it's appropriate regardless of age. If you're 76, in excellent health, and have never been screened before, you might have this conversation with your doctor. But if you're 80 and you've had normal colonoscopies throughout your life, there's very little evidence you'll benefit from another one. Let me tell you about Harold, an 81-year-old patient. His primary care doctor ordered a routine colonoscopy. Harold was reluctant but felt pressured. During the procedure, his colon was perforated. He required emergency surgery, spent 2 weeks in the hospital, developed pneumonia, and never fully recovered his independence. The colonoscopy found nothing: no polyps, no cancer, just a complication from a screening test he didn't need. This isn't rare. It happens every single day. My recommendation: if you're over 65 and your doctor recommends a screening colonoscopy, ask these questions. What is my individual life expectancy based on my health conditions? Will I live long enough to benefit from this screening? What are the specific risks at my age? What happens if we don't do this test? If your doctor can't or won't answer these questions thoughtfully, it might be time to get a second opinion from a geriatric specialist. The second medical checkup I would decline after 65 is routine PSA testing for prostate cancer screening in men. This is controversial, I know. Prostate cancer is common. It's the second leading cause of cancer death in men. But here's what the research actually shows. Most men with prostate cancer will die with it, not from it. The PSA test, prostate-specific antigen blood test, measures a protein produced by the prostate gland. Elevated levels can indicate prostate cancer, but they can also indicate benign prostate enlargement, infection, inflammation, or even recent sexual activity. The problem with PSA screening after 65: first, massive overdiagnosis. A landmark study called the Prostate, Lung, Colorectal, and Ovarian Pelco Cancer Screening Trial followed over 76,000 men for years. The results, published in the New England Journal of Medicine, found no mortality benefit from PSA screening. Another major study, the European Randomized Study of Screening for Prostate Cancer, did find a small mortality benefit, but here's the kicker. You would need to screen 1,410 men and treat 48 men to prevent one prostate cancer death. That means 47 out of 48 men who get treated received no survival benefit, but they did receive the side effects. Second, the treatment side effects are devastating. Treatment for prostate cancer typically involves radical prostatectomy, surgical removal of the prostate, radiation therapy, hormone therapy. These treatments cause permanent erectile dysfunction in 30–70% of men, urinary incontinence, needing to wear pads, bowel problems, fatigue, hot flashes, and bone loss from hormone therapy. Imagine being 78 years old, feeling perfectly fine, getting a PSA test, being diagnosed with prostate cancer, undergoing treatment, and spending your remaining years incontinent and impotent for a cancer that would never have caused you any symptoms. Third, prostate cancer in older men is usually slow-growing. The average age of prostate cancer diagnosis is 66. But many prostate cancers grow so slowly that they take 15–20 years to become life-threatening. If you're diagnosed at 78, there's a very high probability you'll die of something else long before that prostate cancer ever causes problems. A study in the Journal of the American Medical Association found that men over 65 diagnosed with low-risk prostate cancer who chose active surveillance watchful waiting had the same survival rates as men who underwent aggressive treatment but with vastly better quality of life. What the guidelines say: the U.S. Preventive Services Task Force recommends against PSA screening in men over 70. The American Urological Association recommends against routine screening in men over 70. The American Geriatrics Society explicitly recommends against PSA screening in men over 65. The consensus is clear, yet millions of men over 65 still get annual PSA tests, often without any discussion of the risks and limited benefits. When might PSA testing make sense after 65? If you have symptoms, difficulty urinating, blood in urine, bone pain, which can indicate advanced prostate cancer. But again, that's not screening, that's diagnostic testing. If you're 76, in exceptional health with a family history of aggressive prostate cancer, You might have an individualized conversation with a urologist who specializes in geriatric oncology, but routine, automatic PSA testing year after year? The evidence doesn't support it. I had a patient named George, 79 years old. His PSA came back slightly elevated. Biopsy showed low-grade prostate cancer. Against my advice for active surveillance, he underwent radiation therapy. He developed severe urinary incontinence and bowel problems that plagued him for the rest of his life. 5 years later, he died of heart disease. The prostate cancer never progressed. It never caused him a single symptom, but the treatment destroyed his quality of life. My recommendation: if you're a man over 65 and your doctor orders a PSA test, ask, what will you do if it's elevated? Am I healthy enough to tolerate treatment if cancer is found? What's my life expectancy, and will I live long enough to benefit from treatment? Can we discuss active surveillance as an option? Don't let yourself be pushed into a testing and treatment cascade that does more harm than good. The third medical checkup I would decline after 65 is routine mammography for breast cancer screening in women. Just like with prostate cancer in men, this recommendation will be controversial. But let's look at what the evidence actually says. Mammography has saved lives. Early detection of breast cancer in younger women ages 50-69 has clear mortality benefits. But after 65, the picture changes dramatically. The evidence against routine mammography after 65. First, limited survival benefit. A comprehensive review published in Annals of Internal Medicine examined all the major trials of mammography screening. The mortality benefit from mammography takes 5-10 years to appear. If your life expectancy is less than 10 years, you will not live long enough to benefit from screening. The U.S. Preventive Services Task Force states there is insufficient evidence to recommend for or against mammography in women over 65, and they recommend against screening in women with limited life expectancy. Second, significant overdiagnosis. Overdiagnosis means finding cancers that would never have caused symptoms or death in the woman's remaining lifetime. A study in the British Medical Journal estimated that up to 30% of breast cancers detected by mammography in older women represent overdiagnosis. These women undergo surgery, radiation, chemotherapy, and hormone therapy for cancers that would never have harmed them. Third, the harms of mammography increase with age. Higher false positive rates leading to unnecessary biopsies and anxiety. More callbacks and additional imaging complications from biopsies increase with age. Treatment side effects are worse in older women. A mastectomy on a 45-year-old is hard enough. On an 82-year-old with osteoporosis, heart disease, and diabetes, the risks are substantially higher. Fourth, competing health risks. If you're 78 and you have heart disease, diabetes, and COPD, you're far more likely to die from one of those conditions than from breast cancer. Focusing medical attention on cancer screening diverts resources and attention from managing the conditions that actually pose the greatest threat to your life. What the guidelines say. The American Geriatrics Society recommends against routine mammography in women over 65 with a life expectancy of less than 10 years. The American Cancer Society recommends that women should continue screening mammography as long as their overall health is good and they have a life expectancy of 10 years or longer. Notice the key phrase, life expectancy of 10 years or longer. When might mammography still make sense after 65? If you're 76, in excellent health, very active, with no chronic conditions and strong family longevity, you might reasonably choose to continue screening after a thorough discussion with your doctor. If you feel a lump, have nipple discharge, or notice skin changes on your breast, that's not screening, that's diagnostic, and imaging is appropriate, but automatic routine mammography every year or two without any consideration of your individual health status and life expectancy. The evidence doesn't support it. I had a patient named Dorothy, 83 years old, living independently, enjoying life. A routine mammogram found a tiny suspicious area. Biopsy confirmed early-stage breast cancer. She underwent lumpectomy and radiation therapy. The radiation caused severe fatigue. She developed lymphedema, chronic arm swelling. The fatigue led to decreased activity. Decreased activity led to muscle loss and weakness. She fell, broke her hip, and never regained her independence. The cancer they treated was a 4-millimeter tumor that likely would never have grown large enough to cause symptoms in her lifetime. My recommendation: if you're a woman over 65 and your doctor recommends a mammogram, ask, what is my life expectancy based on my current health? Will I live long enough to benefit from finding and treating early breast cancer? What are the risks of false positives and overdiagnosis at my age? What would happen if we stopped routine screening? Make an informed decision based on your individual circumstances, not on blanket recommendations designed for younger women. The fourth medical checkup I would decline after 65 is repeated bone density screening in certain circumstances. Now, this one requires nuance. Osteoporosis is a real concern in older adults. Fractures, particularly hip fractures, can be devastating. But here's the problem. We've created a situation where we're overscreening, overdiagnosing, and overtreating osteoporosis in ways that don't actually reduce fracture risk and may cause significant harm. When bone density screening stops making sense, first, if you've had multiple normal scans, bone density doesn't change rapidly. If you're 77 and you've had 3 DEXA scans over the past 15 years that all showed normal or mild osteopenia, slight bone thinning, there's very little value in getting another one. Bone loss is a gradual process. Once you've established a baseline and confirmed you don't have severe osteoporosis, repeating the test every year or two doesn't change management. Second, if you're already on treatment and stable. If you've been diagnosed with osteoporosis, started medication, and follow-up scans show stability or improvement, continuing to get scans every year may not be necessary. The medications themselves, particularly bisphosphonates like Fosamax, have their own risks with long-term use. Jawbone death, osteonecrosis of the jaw atypical. Femur fractures, ironic fractures caused by the very medication meant to prevent fractures, esophageal irritation and ulcers, severe bone and joint pain. Third, if your fracture risk is already being managed through non-medication approaches. Weight-bearing exercise, calcium and vitamin D supplementation, fall prevention strategies, and home safety modifications all reduce fracture risk. If you're doing these things, repeating bone density scans to chase small numerical improvements doesn't necessarily improve outcomes. What the guidelines say, the U.S. Preventive Services Task Force recommends bone density screening for women 65 and older but doesn't specify how often to repeat it. The American College of Physicians recommends that clinicians should not routinely perform repeat DEXA scans during the 5-year pharmacologic treatment period for osteoporosis. When does bone density screening still make sense after 65? If you've never been screened, a baseline DEXA scan can provide useful information. If you've had a fragility fracture, breaking a bone from a simple fall, a DEXA can help guide treatment. If you're considering whether to start or stop osteoporosis medication, a current scan might inform that decision. But annual or biannual scans in someone who's stable? Not evidence-based. My recommendation: if your doctor orders another DEXA scan and you've had multiple recent ones, ask, how will this test result change my treatment? What's the benefit of repeating this test now? Are we focusing enough on fall prevention, which might be more important than bone density numbers? Now we come to the 5th medical checkup I would decline after 65, and this is the one that could kill you: the comprehensive annual physical with extensive executive panel lab work. This is going to surprise people because we've been conditioned to believe that annual checkups are essential for good health. But here's what the research actually shows. For older adults, especially those over 65, comprehensive annual physicals with extensive screening lab work lead to overdiagnosis, overtreatment, and a cascade of interventions that often cause more harm than benefit. Let me be very clear about what I'm not saying. I'm not saying you should never see your doctor. I'm not saying you shouldn't have regular visits to manage chronic conditions like diabetes, heart disease, or hypertension. What I'm saying is that the traditional annual physical model, where you go in feeling fine and your doctor orders 25 different blood tests looking for problems, is not evidence-based for adults over 65 and can be actively harmful. Here's why. First, the evidence shows annual physicals don't reduce mortality. A landmark Cochrane review analyzed 14 randomized trials involving over 182,000 people. Their conclusion: general health checks annual physicals did not reduce mortality, either overall or from cardiovascular causes or cancer. These checkups led to more diagnoses and more treatment, but they didn't make people live longer or better. Second, abnormal lab values in older adults often don't mean disease. Lab normal ranges are typically based on younger populations. As you age, your physiology changes. What's abnormal for a 40-year-old might be perfectly normal for an 80-year-old. For example, kidney function GFR naturally declines with age. A GFR of 55 in an 80-year-old might be completely normal for their age, not kidney disease requiring intervention. Hemoglobin blood count tends to be lower in older adults. Mild anemia in a senior doesn't always require aggressive workup. PSA levels naturally rise with age in men. A PSA of 5.5 in an 80-year-old might be normal prostate enlargement, not cancer. Thyroid levels shift with age. Subclinical hypothyroidism, slightly elevated CHIS, extremely common in older adults and often doesn't require treatment. But when these results come back abnormal based on reference ranges designed for younger people, it triggers a cascade: more tests, specialist referrals, biopsies, scans, medications with side effects, hospital visits. Third, the cascade effect is real and dangerous. Here's how it typically unfolds: annual physical with comprehensive lab panel. One result comes back slightly abnormal. Doctor orders additional testing to rule out serious disease. Additional test shows something ambiguous. Referral to specialist. Specialist orders invasive test, biopsy, scope, scan with contrast. Invasive test causes complication. Complication requires hospitalization. Hospital stay leads to delirium, hospital-acquired infection, or functional decline. Patient never fully recovers to baseline. I've seen this exact sequence dozens of times. It starts with a routine blood test in someone who felt perfectly fine. Fourth, the psychological harm of overdiagnosis. When you're told you have prediabetes, borderline thyroid, mild kidney disease, or slightly elevated liver enzymes, it creates anxiety and medicalizes normal aging. You start thinking of yourself as sick when you're actually fine. This can lead to depression and anxiety, reduced activity due to fear, unnecessary dietary restrictions, taking medications you don't need, endless follow-up appointments. The real-world example that haunts me. I had a patient named Eleanor, 78 years old, active, independent, sharp as a tack. She went for her annual physical, feeling great. Her doctor ordered a comprehensive metabolic panel, complete blood count, lipid panel, thyroid function, liver enzymes, kidney function, urinalysis, and tumor markers. 23 different tests. One result came back. Her alkaline phosphatase, a liver enzyme, was slightly elevated at 135. Normal is up to 120. Her doctor ordered more liver tests. Those showed a slightly elevated GEAT, ultrasound of the liver. The ultrasound showed a small indeterminate lesion. CT scan with contrast to better characterize the lesion. Eleanor had an allergic reaction to the contrast, developed acute kidney injury, became confused, delirium, fell in the hospital, fractured her hip, underwent surgery, developed pneumonia in the hospital, spent 3 weeks in ICU, and eventually died. The lesion on her liver was a benign hemangioma, a collection of blood vessels that's incredibly common and completely harmless. She died because of a cascade that started with a screening blood test she didn't need. What does make sense after 65? Regular visits with your doctor to manage known conditions, diabetes, high blood pressure, heart disease. These need monitoring and management, targeted testing based on symptoms or specific concerns. If you're having symptoms, appropriate diagnostic testing is essential. Medication reviews to ensure you're not taking medications. You don't need functional assessments. Vision, hearing, balance, cognitive function, nutrition, fall risk. These affect quality of life and independence far more than most lab values. Discussion about advanced directives, goals of care, and what matters most to you. What the guidelines say: the U.S. Preventive Services Task Force does not recommend for or against routine annual physical exams. They recommend specific evidence-based screenings based on age and risk factors, not blanket testing. The American Geriatrics Society recommends against annual screening with resting or stress electrocardiography, routine urinalysis, and many other tests in asymptomatic older adults. The Choosing Wisely campaign, an initiative to reduce overuse of medical tests and procedures, has multiple recommendations against routine screening tests in older adults. My recommendation: if your doctor wants to order extensive lab work at your annual visit, ask, what specific conditions are we looking for with each of these tests? How will the results change my treatment or improve my health? What happens if we don't do these tests? Are these tests recommended by geriatric medicine guidelines for someone my age? And consider shifting from an annual checkup model to a chronic disease management and functional health model. Focus on maintaining strength, balance, cognitive function, social connection, and independence rather than chasing lab values that may or may not be meaningful at your age. Let me bring this all together. We've talked about 5 medical checkups that I would personally decline after age 65, routine colonoscopy when the time to benefit exceeds life expectancy, PSA screening for prostate cancer, massive overdiagnosis with devastating treatment side effects, routine mammography when life expectancy is less than 10 years, repeated bone density scans when results won't change, management. Comprehensive annual physicals with extensive lab work, the cascade effect that can kill. I want to be absolutely clear. I am not advocating for neglecting your health. I'm advocating for smart, evidence-based, individualized medical care that considers your age, your health status, your values, and your goals. The medical system is designed to find and fix problems. That's generally good. But when you're over 65, aggressive screening and testing often creates problems rather than solving them. Quality of life matters more than quantity of diagnoses. Functional independence matters more than perfect lab values. Avoiding harm matters as much as detecting disease. These are concepts that geriatric medicine embraces but that mainstream medicine often ignores. I encourage you to have honest conversations with your doctor, ask questions. Understand the why behind every test. Know the risks, not just the potential benefits. And if your doctor becomes defensive or dismissive when you ask these questions, it might be time to find a doctor who practices evidence-based geriatric medicine. Now, I want to hear from you. Drop a comment below. Are you over 65? Have you had any of these tests recently? Have you experienced a testing cascade that led to complications? What questions do you have about navigating medical care wisely as you age? I read every single comment and I respond to as many as I can. If this video gave you valuable information, share it with someone over 65 who needs to hear this. Share it in your community groups. Email it to your book club. This information could prevent someone from going through unnecessary testing that harms rather than helps. And subscribe to this channel for next videos on evidence-based health information for older adults. I'm here to give you the truth even when it's uncomfortable. You deserve medical care that serves your best interests, respects your autonomy, and honors your goals. I'm Dr. Novamind. Take control of your healthcare decisions, and I'll see you in the next video.